Okay, so I was asked to talk on surprises in pediatric infectious disease. And I think all of us come across some or the other surprises that are there. Sometimes we think it's an infectious disease and it turns out to be some genetic disorder. Sometimes it turns out to be some malignancy. Sometimes it turns out to be an autoimmune, especially in PUOs. We think it's a malignancy or autoimmune. So, what I'm going to discuss is a few cases that have really surprised us in clinical practice. And so this is a 6-year-old female child. She came with fever and abdominal pain for a week. An ultrasound was done outside by the doctor there. And he found that there is liver abscesses, multiple liver abscesses. He started the child on piperacillin tazobactam. I'm not going to talk on whether this was the right antibiotic or not, but because there was no response and the blood culture was no growth, they sent the child to us for further management. Now, because it was a USG which said that there was multiple liver abscesses, we did an CT scan. And you can see that arrow, you can see these target lesions on the CT scan. So there were multiple such lesions in the liver, which was giving like a target-like appearance, suggestive of liver abscesses. And then if you look at the counts, you see that there is leukocytosis, not much of neutrophilia, but you do see some eosinophilia. Now this was a little surprising. Why is this child having eosinophilia? And CRP is high. So what would you do in such a scenario? You're not able to do biopsy of these lesions. There are multiple small lesions. So would you change the antibiotic? The commonest organism in liver abscess is Staph aureus, and then comes gram-negative. So Piptaz was not the ideal antibiotic because you want to give something that covers Staph aureus. But the clue here was the eosinophilia, and the child just not responding. We thought of parasites because parasites are other things that can cause. It didn't fit like echinococcus because echinococcus does. So echinococcus doesn't have these kind of lesions. And if you look at Entamoeba histolytica, it's not going to be multiple lesions. It's going to be a single lesion sitting there. So in this child, what could be the cause of the liver abscess? Now, again, you have eosinophilia, you have this kind of thing. So we went into the history, and there was a history of a cat in the house. And when you have a cat in the house, the first thing that comes to your mind is toxocara. How do you prove it? Toxocara. You don't have any ELISA tests that are available. So what we did is we asked the parents of the child to send the stool sample of the cat for testing. And that stool sample showed toxocara. So the treatment here was albendazole. We actually stopped the antibiotics and we just gave albendazole for 14 days. And the child was doing well on follow-up. So what's the key message? That when we talk about liver abscesses, we talk about pyogenic, we talk about amoebic, but do not forget the parasites. And always ask for, in an infectious disease case, always ask for history of animal contact. You will be surprised by the kind of contact that they have. Sometimes they have contact with sheep, sometimes with turtles, sometimes with reptiles, sometimes with rats. And a lot of times your cause of fever may be just an animal contact, a zoonosis. So we talk about a lot of infectious disease mimics. And I see a lot of people in the audience have this similar kind of a smile. So you have a second case. Now this is classical 4.5-year-old boy, productive cough, hemoptysis, fever for a year, chest x-ray showing right lower zone consolidation. You're going to think of TB. You're given first-line AKT for 6 months as clinically diagnosed TB, had no response, and then was referred to us as a suspected drug-resistant TB. Now, if you look at this boy, he's got scoliosis. He's very malnourished. He's 4.5 years. Weight is 7.8 kilos. So he's very, very malnourished. Height is 85 centimeters. He's got clubbing, and he's got severe scoliosis. Again, you will think this is TB-induced scoliosis. And you see the x-ray, and the x-ray is showing this kind of a patch on the right lower zone, and you think this is really a drug-resistant TB. So we did an HRCT because we just wanted to make sure that we're dealing with TB, are there glands, is there fibrosis? And what you see on the HRCT is consolidation in the entire right lower lobe without an air bronchogram. So that's the most important clue. There's an air bronchogram. The right lower bronchus is getting abruptly cut off, and you can see these multiple feeders. I don't know, it's not showing you. You can see these multiple feeders coming from the aorta. Any guesses what we are dealing with? Yes, it could be a sequestration. So this is a right lower lobe sequestration. So the treatment is not TB actually. So it's very similar picture, cough, hemoptysis, fever for a year. So we are in an era where earlier we used to diagnose TB clinically. We are in an era where we have microbiological diagnosis. So I think if you're treating anybody for TB, make sure you have a microbiological or at least a histopathological evidence to say it is TB. So the key message here is that not all non-resolving pneumonia is TB and not all patch on an X-ray is pneumonia. So always look for an air bronchogram on a X-ray chest. If you don't see an air bronchogram, you're dealing with something else. Now, because I was asked, surprising in pediatric infectious disease, I said we have to spot the difference because some things just look the same. Again, a 10-year-old girl, she has fever and cough and breathlessness with weight loss for a month. She has received anti-tuberculous therapy at the age of 11 months for 6 months, so quite a long time back. And now again, she's come with fever, cough, breathlessness. Her weight is 16 kilos at 10 years. She's got clubbing and she's got fine inspiratory creps all over the chest. What's your clinical suspicion? Yeah, she's got fever, cough, breathlessness with weight loss for a month. So you think that this could be bronchiectasis, this could be TB. Now you see this X-ray. And this is the kind of X-ray that she has. Her saturations are 98%. Yes. So this is her X-ray. You think this is miliary. And the surprising part is the ESR is only 9. Okay, so we do a CT, and this is the CT. It is showing extensive interstitial septal thickening, crazy paving pattern. Now, do you think this is TB? Doesn't look like TB. So what would you do next? Okay, we could do a lung biopsy or we could do a BAL over here because this looks like something else. This looks like a pulmonary alveolar proteinosis. It's a surfactant problem. So a BAL fluid macrophage was sent and that showed the diagnosis of pulmonary alveolar proteinosis. Treatment here is very different because a surfactant is known to accumulate. You just need to wash out the surfactant. So the BAL was actually helpful because you actually did a lavage and removed all that surfactant. But there's a twist in the tail, not like this, but there's an actual twist in the tail. The BAL was sent for TB. And now you've got AFP positive. So do you treat, so can you spot the difference now? Do you treat TB or you treat pulmonary alveolar proteinosis? So do you treat this TB? You have an AFP positive. Do you treat the TB? Okay, so probably the child is so malnourished, so you give a thought, that probably she has a secondary TB sitting there. So let's give a trial of TB treatment. So we did give her a trial of TB treatment, but the TB culture came negative at 6 weeks. So even though AFP was positive, the culture was negative. We actually stopped her therapy after that. So why do you think now that this AFP was positive? You have lots of causes. I remember a child which I had seen in my clinic. This child had come to me as hematemesis. And somebody thought it was hemoptysis and did an AFP and it came on a gastric lavage and that came positive and then was referred to me for starting. So I first found out which lab was doing it and I found it was some obscure lab in one of the suburbs of Mumbai. I called up the lab person. I said, tell me your technique of doing AFP. And then you remember in your MBBS days how we used to do AFB and how we used to wash the slide with water. So I asked them, which water are you using for washing? And they told me tap water. So your tap water is a source of NTMs. So one is your lab contamination. And that child was started on AKT, had to stop his AKT, that there is nothing. So the most important thing is your AFP could be positive. One is because of NTMs, which may be just contamination. Second thing, you have used improper dilution. You have seen some AFP in a previous slide, that oil has remained back on the lens. And then this happens a lot of times with bronchoscopy. Suppose they have taken a child for bronchoscopy and they had the first child who was MTB, and if they've not washed the bronchoscope properly, then subsequently all bronchoscopies will grow MTB or gene expert positive. So that kind of contamination. So be very careful when you interpret that AFP positive and culture negative. So the key message here is that one is miliary shadows on X-ray chest is not TB all the time. If you look at this article, which I found, an exhaustive differential diagnosis of miliary TB, and nowhere it was pulmonary alveolar proteinosis, which I think is a rare condition. But keep in mind that everything is not TB, okay? So when I was coming here, somebody asked me, TB or not TB, to be or not to be. So I think we have a referral bias, we see a lot of TB. So we are actually picking out a needle out of the haystack to say this is not TB. Okay, so make sure that every fever is not TB. I think if RNTCP hears me, they're going to kill me for this, but saying even fever more than 15 days, think of other causes apart from TB. So the key message here is not all miliary looking shadows are TB. Not all positive AFP means TB. Not all non-improvement with anti-TB drugs means drug-resistant TB. Always look for alternative diagnosis. And the thing is, as doctors, at least the feedback that I get from my non-medical friends is you doctors are very arrogant. You all can never say that you're wrong. And that's the problem why I think the medical reputation has gone down, because we always tend to say, oh, this fellow was wrong, I'm right. We never tell our colleagues were right, and it's possible. So we always say we are right and they're wrong. So that's why my non-medical friends always tell me, doctors are very arrogant. Now, you have a female baby born to a 20-year-old mother by LSCS. The baby is full term, 2.8 kilos, length is 51 centimeters, head circumference is around 32.5, little borderline, no dysmorphic features, baby is well discharged, went home. Day 4 comes back with convulsions, and these convulsions are continuously going on. Now, if you go into the antenatal history of the mother, she is gravida 2, para 2, and she has 2 living children. The first one is 18-month-old male, he's absolutely normal, and the second one is the current child who's born. The mother does not have any fever, rash. Why I'm presenting this case is because we tend to ignore a lot of antenatal and perinatal infections. In fact, we've now started a clinic at Vadia where we have a specific just antenatal and perinatal infections clinic. And my fellow is also going to present a case on CMV, congenital CMV, and how the diagnosis was actually made. It was not that simple. So here you have this child who's had convulsions, and this child is admitted. You see the septic workup in the child is absolutely normal, including the CSF is not really showing any abnormality. 13 cells at day 4 is not bad. It's almost a normal CSF. You have CRP, which is normal. So septic screening is normal. You think electrolyte disturbance, that is normal. You think of TORCH group of infections. Now, if you look at the TORCH group of infections, all the IgMs are negative in the mother and the baby. The baby's titers are all less as compared to the mother's titers. So indirectly that the baby is not producing any antibodies. So it doesn't look like any infection, congenital infection. A BERA is done. And the BERA shows hearing loss in both the ears. An MRI brain is done, and that radiologist tells us that this is congenital CMV. Okay, your torch is not giving you any idea. There is calcifications, there is paucity of the periventricular white matter, there's diffuse thinning of the corpus callosum. So this is the MRI picture. You can see this calcifications. You can see the dilatation of the lateral ventricles. And so this is the MRI picture. Classical congenital CMV on radiology. What would you want to do? You have a TORCH IgM. This is what you will be seeing day in and day out. I mean, if you are attending normal deliveries or you're tied up with a gynec and you're doing deliveries, you will sometimes land up with these kind of scenarios. Okay, so you want to do a fundus and you want to do a PCR. Urine PCR, okay. So we did a urine PCR, that came negative. We did a blood PCR, that came negative. We did a salivary PCR, that came negative. We actually went and did the mother's saliva. Fundus was normal. We did the mother's saliva. We did the mother's breast milk CMV. Everything. We did a CSF PCR. Everything is negative. So all the CMV PCRs are negative. Do you want to? And the radiologist is very firm that this is congenital CMV. There's nothing else. You have a hearing loss. You have PCRs negative. Do you want to start valganciclovir? Now, treatment of congenital CMV is basically going to be 6 months of valganciclovir. So, do you want to start that? Nothing else, nothing else. You just have intracranial calcifications, convulsions, hearing loss, a little bit of microcephaly. So you think of what could be a radiological similarity to congenital CMV, and that could be a pseudo-TORCH, which is an autosomal recessive condition. It mimics an intrauterine TORCH group of infection. You could have congenital microcephaly, calcifications, developmental delay. You have a second syndrome that is known as Aicardi-Gautier syndrome, which could be the other differential diagnosis. How do you prove that? You will have to do a genetic test here. So now this was a dilemma we've been facing because we started this antenatal clinic for about 2 months. And we've seen multiple number of patients like this where the radiologist has said, this is congenital CMV, you have to treat. And then when we go into further details, either sometimes, the breast milk comes positive CMV or the stool comes positive, but you don't get a clear-cut picture, urine PCR positive, saliva positive, blood PCR positive. What do you do? And the case that Vaide is going to discuss in her poster, actually we did a genetic test and that also confused us even more. Okay. So the thing is, observe these patients. You don't have idea at that moment in time whether you're going to give Valgan or you don't want to give. Observe these children, see how they are behaving over a period of time. This child is currently under follow-up. So we will be observing him and seeing. We've been pestering the parents to do a genetic test, but they say no money, no money. So once they are convinced, we'll do a genetic test and we'll get a better idea. But till that time, you will have to weigh the pros and cons, whether you want to give valganciclovir or you don't want to give. So the key message here is that not all intracranial calcifications is congenital infection. You need to do appropriate test to determine the right etiology. And how much time do I have?
5 minutes.
I have 5 minutes, so I'm going to give 5 minutes extra to the organizers. So you have lots of surprises in pediatric infectious disease, and you have lots of surprises as patients too when the healthcare system comes out with, if they don't have insurance, they get a surprise of their life at the time of discharge. So there's one surprise that we have. Then the surprise that we as doctors get, they come out with printouts. This is what I have. Now you prove it that this is what I have. So they become experts at Google search and everything. So that's the surprise that we get. And then the billing surprise is the surprise for them. And then we have surprises when we do clinical trials and we find, oh, this is not what I wanted to prove and I'm proving something else. So surprises are never ending in pediatric infectious disease. I could go on and on with all the cases that we've seen. But the whole thing is, let's not be rigid. Let's be very flexible in our approach. Accept opinions, which we, sometimes even if we take opinions, we say, no, this is what I think and this is what I'm going to do. Be flexible. So the key message is be flexible and be positive. Not that blood group, be positive. but be positive. Thank you very much. Any questions?